Welcome, Kate.
Thank you. Let's see, how do I work this thing?
Forward,
just forward and back?
And pointer.
I think I should be able to work that out. Hi, everyone. It's exciting to be here. I don't know if Joy knew this when she contacted me, but the best way to lure me halfway across the world is to offer me the opportunity to talk about cat flu. I find this a subject of endless fascination. And I'll be quick about this, but really, in a way, the thing that got me into shelter medicine, so I worked for 6 years as an animal control officer and animal care attendant before I went to vet school, and one of the defining moments of my career, although I didn't recognize it then, was when I had a foster litter of kittens, and I named them Small, Medium, and Large Orange, and Callie the Calico, and I raised them up, and then when they were of age, I brought them back to the shelter where I worked, and Callie got adopted immediately, and Medium Orange got adopted quickly, but the other two stayed for a few days, and then one day I was walking into the euthanasia room, and I saw Small and Large Orange being euthanized. And our rule at the time was you didn't question a euthanasia decision. It was hard enough to make those choices, and so I just walked out of the room. But there was a little voice in my head that said, there's got to be a better way. And when I went to vet school, and I saw all the different amazing things we could do and all that we knew and all the skills and tools that we had, I thought about those two kittens and just like the trivial infection that claimed their lives. And I thought, there's got to be a better way. And I went immediately from vet school to working in an animal shelter because I thought, I'm going to figure out a better way. And I'm going to, instead of euthanizing those cats, we're going to treat them, just a few dollars worth of antibiotics, and they could be better for their whole lives. And about 6 months later, I was standing in the hallway outside of our feline upper respiratory infection treatment room, and it was full. And there was a stack of carriers with towels over them of cats with upper respiratory infection waiting to go in. And I was trying to figure out, should I euthanize some of the ones I started treating already? Should I euthanize some of the ones that I haven't started treating yet? Which cats should I kill today because of this stupid infection? And I thought, there's got to be a better way to deal with this. So when the opportunity came to do a residency in shelter medicine, 3 years of advanced training, where I could think about nothing but this all day, every day, for years on end, I thought maybe that's the better way. And it has taken some years, that was 10 years ago, to get to this point. But I'm happy to say, I think we've really figured out that there actually is a better way to manage cats and manage upper respiratory infection. It's not a super easy way, but I think the great news is that there's a lot of other good that comes out of the same strategies that are successful for managing feline upper respiratory infection, or cat flu, as you more cutely call it. How many of you are here for my day-long extravaganza? Okay, so about half. Sorry for you, I'm going to repeat a few things, but it's all so critical that hopefully you won't mind too much. For those of you who don't know, our website is sheltermedicine.com. There's detailed notes that go along with these slides in your proceedings. We also have detailed notes on feline upper respiratory infection and many other diseases of interest in shelters on our website, and we often share breaking news and new research and pictures of us petting koalas on our Facebook page at facebook.com/sheltermedicine. Oh, excellent. So I don't have to get that up there. So, this is a conference about getting to zero. And what does cat flu have to do with getting to zero? Is controlling cat flu just a nice aside that we would like to do while we're getting to zero? Or is controlling cat flu something we need to do to get to zero? I would argue that if it's not a necessary piece of getting to zero, it's at least something that will hasten getting to zero. There's a lot of costs to cat flu besides just snot-nosed, sneezing, miserable cats. And in the picture on the right here, I don't know if you can really see that, But this is from a study that we did tracking upper respiratory infection, or cat flu, at shelters in North America over a year's time. And this is just a typical month for that shelter. And in that shelter, for that month, they spent 1,460 days caring for healthy cats. One cat, one day means one cat day. And 722 days caring for cats with upper respiratory infection. So this was a shelter that treated most cats to recovery unless they were really very ill. So it didn't actually directly claim any cats' lives, or not very many cats' lives at that shelter. But if it took a third of their cat care resources, that had an impact on how they were able to serve the public, how rapidly they were able to answer the phone, what else their veterinary staff wasn't doing, like spaying and neutering cats, and what they were able to do to prevent unwanted cats from being born in the community. So feline upper respiratory infection can be an enormous resource drain. And then on the right is an article, and I don't think you can see that, but it's a sad cat's tale or visit to the shelter, and it was a letter to the editor that was published in my local paper about my local shelter. This person's cat came into the shelter, spent a few days there. She came in and reclaimed the cat, brought it home. It was very ill. She spent $1,500 at the vet getting through its upper respiratory infection, and it gave whatever it had to her other cat, and her other cat died. So that wasn't good for her or her cats. But also, what did it do for the shelter to have this letter in the paper? And even if it's not a letter in the paper, how many of you think that out in the community, people talk when they get a cat that has upper respiratory infection from a shelter, and that makes them not recommend a shelter cat as a place to get an animal? And if they don't get an animal from the shelter, maybe they go and get an animal from the next door neighbor, and they don't desex that animal, and they don't microchip that animal, and that animal ends up contributing further to the overpopulation problem. So I don't think we can get to zero. We certainly can't get to zero as fast unless we get a handle on feline upper respiratory infection. We also want to think about what zero are we getting to? And oftentimes, an initiative to get to zero can lead to an increase in shelter holding, which can lead to an increase in shelter crowding, and sometimes an increase in illness. So this is a graph from a shelter that had an initiative to achieve zero euthanasia of healthy and adoptable animals. And you can see, or I hope you can see this, their healthy euthanasia as a percent of total euthanasia, so this isn't their total euthanasia, but as a percent of total, went down during these years. So there was a pretty sharp drop, and then they maintained it, and then it went up again. So they increased the percent of animals that they were euthanizing healthy. And if you're trying to end the euthanasia of healthy and adoptable animals, you want to see healthy euthanasia drop, right? Except, what happened to their overall euthanasia and shelter death? So the maroon parts of the bars are the unhealthy euthanasia, and then the yellow that kicks in is shelter death. So we start to see a visible amount of shelter death. And so what we saw is that although the healthy euthanasia went down, the sick euthanasia actually went up, and overall there was an increase in shelter death rate. So that can be, with a big push to not euthanize healthy animals, unless you're getting them out the door successfully or keeping them from coming in the door successfully, they can convert over to sick animals, and even, in fact, more animals can end up getting sick and getting euthanized. So when we're getting to zero, we want to be sure we get to the right zero, not just get to zero of no animals stay healthy in our care. So this is risk for upper respiratory infection at a pretty typical shelter in the United States. And you can see this is over time, and it progresses to almost 100% risk for respiratory disease by the time the cats have been in the shelter for about 2 to 3 weeks. And overall, and this is pretty typical to what we often see, about 600 out of about 2,000 cats got sick, so a little under a third. Would most of you say that's about what you see? How many see more than that? Where more than, say, half or more of your cats, if they stay long enough, they'll end up getting respiratory disease. A few of you. How many of you would say less than 20% of your cats, if they stay with you, will get respiratory infection? few. And I guess the rest of you are somewhere in the middle, between 10 and 50%. Is that right? Okay. This came out about the same time. This is also upper respiratory infection risk over time, but this came out of the UK, and instead of increasing by day in the shelter, the risk actually decreased, so cats were becoming safer with every day in the shelter's care. And only about 60 out of about 1,400 cats got upper respiratory infection. So that was a really striking finding. What's going on? Do they just have better cats in the UK? So we looked at it for a year in the United States, or in the US and Canada, and we found, in fact, that there was an enormous range in the risk of upper respiratory infection, and it varied by shelter. And it didn't vary by the health of the incoming population. So we tested to see if the cats were just more germy when they walked in the door at some shelters, and that wasn't the explanation for this change. And the risk actually varied over 50-fold from less than 1, this is on a per cat per day basis, to about 35 on a per cat per day basis. And this is actually the lines from 3 of the shelters. So you can see there's this blue line, hardly ever crosses this green line, then this sort of medium shelter, and then this high upper respiratory infection disease rate shelter. So we got really interested in what that was all about. So this is the great news. Upper respiratory infection has seemed like an inevitable part of sheltering for a lot of us from time immemorial. And in fact, it can be a rare event. 60 out of 1,400, pretty rare event. The not such great news is that there's not a real easy answer. So there's not a nutritional supplement or a vaccination strategy or a great way to treat them that just gets them all better right away, even really hitting hard on cleaning and disinfection, keeping the cats all sterile, not going to do the trick. So what we actually have to achieve to control upper respiratory infection is excellent stress prevention from the minute a cat enters our care or from a little before, high-quality housing, attentive daily care, and conscientious population management. And those are just 4 things to say, but it's a fair amount to do. But the good news of the bad news is that when we do those things, a lot of other good things happen as well. So, I'm going to talk a little bit about what causes upper respiratory infection. And we've often thought that it's mostly one of 2 viruses, herpes virus and calicivirus. Are you all familiar with those 2 viruses? Raise your hand if you've never heard of them. Okay. And in pet cats, it may well be that calicivirus and herpes virus play an equal role. But we looked at some of the shelters that participated in our upper respiratory infection study at what viruses were present in the cats on intake. And here's calici and here's herpes. And the blue line is on intake. And the red is in cats with upper respiratory infection. You can see there was hardly any change in the frequency of calicivirus in cats with upper respiratory infection, and on intake, looking perfectly healthy. And in fact, there was no statistically significant difference there. But look at herpes virus. And that's been supported. Now there's been a good handful, almost a half dozen studies published, where herpes virus plays vastly the predominant role. Does anybody know why that is who wasn't here on Tuesday? Latent recrudescence, that's right. And why? Stress. Herpes is directly stress-associated. So while we may see calici as a player in pet cats where stress doesn't play an enormous role, herpes plays the overwhelming role in most shelter upper respiratory infection. You can see, here's the other players. Chlamydia was associated with upper respiratory infection, but very rare. Bordetella occasionally was associated with upper respiratory infection, but when we took out 1 shelter for 2 quarters, then the association disappeared. So it's a sporadic problem. It's not a background, ongoing, grinding problem. Mycoplasma is probably a player in enhancing the severity of disease, and so we need to think about it when it comes time to think about treatment, because mycoplasma in itself is a respiratory immunosuppressant, so it makes other diseases worse. So it's bad in a shelter where other diseases are present, but it does not in itself seem to cause a significant proportion of shelter respiratory infection. Now, here was one shelter where we saw a really different pattern, where herpes virus was equally common in cats on intake and in cats with respiratory disease. It was actually a little less frequent in sick cats, but it wasn't statistically significant. And calicivirus was much more common. And in fact, we saw chlamydia also playing a role, and mycoplasma also playing a role, and bordetella being a little more frequent. That was the shelter that had 0.7 cases per 1,000 cat days. That was that bottom line that barely ever poked up. So they had very low upper respiratory infection overall. What was left was caused by the other players. So when you get rid of all the herpes, what you see is not very much upper respiratory infection, and what little you see is probably the other guys. So you'll see outbreaks in a shelter that has a lot of upper respiratory infection, and you'll see sudden spikes where it's worse or it's more frequent, caused by the other guys. But you can't get rid of upper respiratory infection unless you get rid of herpes. And what this shelter was doing an excellent job of controlling stress and also setting themselves up for success with housing and a management strategy that facilitated easy daily disinfection and care. So just the basics of herpes versus calicivirus. For both of them, the carrier state is common. And so this is important for you to know, and you saw it reflected in the data of cats on intake. Cats walk in the door of animal shelters across the world every single day with herpes, with calici, with all the common players in feline upper respiratory infection. And that's important to know because when they recover, they're also still part of that pool. And there's no need to be especially concerned about a cat that's recovered from upper respiratory infection. As long as its signs have completely resolved, then it's just another cat that has herpes or calici or bordetella or mycoplasma in your population. The only real exception for that is cats that are affected by a particularly severe outbreak of calicivirus that either causes bad signs or causes signs in otherwise fully vaccinated, healthy adult cats. The other thing to realize is that, I mentioned this herpes virus stress-associated. Calicivirus also has a carrier state, so it's also commonly shed by shelter cats or by any cat from a multiple cat background, but it's not stress-associated in particular. So you can't predict the shedding in response to stress. They just shed whenever they feel like it for whatever time period they feel like it for. So it's a question we fairly often get. What do you do with a calici-recovered cat or a herpes-recovered cat? And the answer generally is, unless it had something really weird going on, you do the same thing that you do with the cat that you got in that hasn't had its outbreak of herpes or calicivirus yet. Herpes virus is rarely vaccine resistant, so the vaccine isn't very good against herpes virus, but there's not strains that just break all the way through the vaccine. So for pet cats, which are almost always vaccinated against herpes virus, it's unlikely that a shelter cat is going to give a pet cat a bad upper respiratory infection caused by herpes virus. There are vaccine-resistant strains of calicivirus that just break all the way through the vaccines, and the vaccine provides no protection whatsoever. And if you have an outbreak in your shelter where vaccinated cats are affected, or it's being brought home to technicians or staff members' cats, then that is a strain to be much more worried about. This is something that is still amazing to a lot of people, but we've actually known it since 1977, and this is one of those articles that I read through when I was a resident that I was just astonished to see. Studies have been done with cats that had both herpes virus and calicivirus sneezing like crazy, spread just a couple of meters apart in a small, poorly ventilated room. And as long as staff was meticulous about always handling the healthy cats before they handled the affected cats, there was no transmission of disease. Cats' cute little lungs just aren't powerful enough to generate a true aerosol. So they can spray droplets a meter or two. So cages shouldn't be closer than good arm's length apart or more. But they don't generate a true aerosol that rises into the air and drifts down a hallway and drifts into another room and lands on another cat. And that can help us with management because air quality is very important. And just opening windows, increasing ventilation, putting fans in stuffy rooms so that there's not urine fumes and disinfectant chemicals and hair and crud in the air that cats are trying to breathe can benefit both them not getting respiratory infection and them recovering more rapidly should they get sick. It sometimes seems like it travels through the air. It sometimes seems like it's in the water at animal shelters. And the reason is probably in large part because of the stress association of herpes virus. They come in carrying herpes virus fairly often. Pregnancy and birthing specifically activates herpes virus, and that's part of herpes strategy so that it gets passed on to the newborn kittens before they can really think about defending themselves. And often we have pregnant or nursing mothers and kittens in our care. Moving a cat from one cage to another was enough to activate herpes virus in 20 to 80% of cats in 2 different studies. And introduction of new cats, especially intact new cats, into a group can also be a powerful activator of herpes virus. And the tricky thing is that it activates it with signs in about 50% of cats and without signs in the other 50% of cats. So it takes about 7 days to turn it on. So if you bring a group of cats into a shelter, you freak them out, and you wait 7 days, half of them are going to start sneezing, and the other half of them are going to be shedding but not showing any signs. You handle the half that are shedding and not showing any signs and touch some other cats that don't have herpes yet, and guess what? Then you've transmitted it to the ones that didn't walk in the door already carrying the disease. So it's a tough disease to manage in a shelter environment. We have nothing like this really for dogs. We don't have something for dogs that's turned on by stress. That's why we don't tend to see the same horrendous problems sometimes with canine respiratory disease, even though it is airborne, so in some senses it's more difficult to contain. So why bother with diagnostics? Every once in a while it can be really helpful. One thing would be just to demonstrate to yourself, really? Herpes virus? Is it really a problem in my shelter? I feel like we're doing such a good job. So just to one time get a sort of baseline sense of what is causing respiratory infection in your shelter cats. And I have some information in the notes about what are some of the expected prevalences of these things in cats that don't have respiratory infection, so you can compare it against sort of background expected levels. Or if you have an outbreak of more severe, more frequent, or certainly if you have disease that's progressing to fatalities in any animals, then it's worth knowing what you're dealing with. Maybe it is Bordetella, and then you want to make sure you're treating with an antibiotic that gets Bordetella. Or maybe it's chlamydia. There's a particular treatment strategy that you'll need to know for that. And how long do I have, Joy?
We started late, so you've got till 2:25 if you need it. If you're a little bit shorter, that's fine, but
all right.
It's your hour.
I'm never short.
No, you won't be. That's fine. So good to 2:25.
So I used to torment everybody by talking about prevention before I got to treatment, then I would never get to treatment. And I admit treatment is important when you're dealing with upper respiratory infection, especially when you haven't had time to implement preventive strategies that sometimes take a little bit longer and require some planning and some training and sometimes even some fundraising and some roof raising. So treatment is important. Do all of you pretty much treat some cats with upper respiratory infection? So certainly in the days, like at my shelter where we didn't treat any upper respiratory infection, it was very difficult to notice sneezing cats. And effective treatment is important because if you have ineffective treatment, you just have cats languishing, increasing the overall load of upper respiratory disease in the shelter. So if you're going to treat, you want to isolate effectively and you want to treat effectively. And you want to make sure that you have the staff and the wherewithal to do that. So even though the great majority of respiratory infection that you deal with is probably caused by feline herpes virus, and some of it is caused by those 3 primary viral infections, Mycoplasma, Bordetella, and chlamydia. Also, there's lots of secondary bacterial infections just floating around in shelters, waiting to colonize once herpes virus or calicivirus has given them a head start by compromising the respiratory tract tissues. So we see Pasteurella, we see E. coli, we see strep, we see staph. So we see a mix of gram-negative and gram-positive bacteria. And that's important to know because we need to choose antibiotics that have a broad spectrum, including a spectrum against gram-negative bacteria, if we feel like there's a secondary bacterial infection. Then we also have mycoplasma, and as I mentioned, probably contributes to worsening symptoms by causing respiratory immunosuppression on its own, as well as being somewhat pathogenic all on its own. It has no cell wall, and that rules out several big classes of antibiotics. That's all the penicillins and all the cephalosporins act on the cell wall, and so by definition, they won't get mycoplasma. So Clavamox, amoxicillin, ampicillin, cephalexin, not very good choices for upper respiratory infection if you think you might be dealing with mycoplasma. And then chlamydia and bordetella, sporadically they are important and they are intracellular, and there's only certain drugs that penetrate intracellularly. Notably, doxycycline is a good intracellular antibiotic. It's effective against mycoplasma, pretty consistent against bordetella, and the only drug that routinely, effectively eliminates chlamydia. So it's good as one choice, but you also have to have another choice available that's better against gram-negatives because doxycycline isn't very good. This is a picture of a cat in an upper respiratory infection treatment ward, and this is a picture of the air in that ward. This is just a device that we have that blasts air through a filter onto a bacterial culture plate. And so you can imagine why his nose is looking like that, because the air is looking like that. So if you often find that you're treating for severe bacterial infection, if cats end up looking like that, think about the conditions in the area where you're treating and make sure that the air quality is good, that stress management is good, and that cleanliness is appropriate, whether that's an isolation ward at your shelter or whether that's a foster home where things have gotten a little out of hand. So I used to say, always wait until there's signs of secondary bacterial infection before you initiate antibiotic treatment. But in a shelter environment, time is of the essence. Days of care equals life and death for cats. Even if you're a limited intake shelter and you're not euthanizing for space, if you're slowing down the process, that's limiting the number of animals that you can admit. So we want to be really stingy with our days of care, and we want to have a treatment approach that is as fast as possible. So if you find that you always end up having to start cats on antibiotics, do revisit your air quality, your stress management, your cleanliness in your treatment area. But in the meanwhile, as long as that's true, go ahead and start antibiotics right away. If you don't always need to start antibiotics, if sometimes they just have a little clear nasal discharge and some sneezing, then go ahead and wait and see which path they go down. So does that make sense? So that's a different recommendation from what's commonly in the literature and what I've recommended in the past. And that's because we found that for shelters that always needed to start treatment, if they went ahead and started treatment right away, it tended to shave a few days off the time that the cat spent in the treatment area. You want to choose an effective drug at the highest safe dose. That's also sort of a departure from what we used to recommend, where we'd say start with ampicillin. We know it doesn't work, but it's just benign. In fact, the risk of selecting for antibiotic resistance, and not just in the respiratory tract, but in the GI tract and bacteria that could be pathogenic to humans as well as to cats, is going to be higher if you're using an ineffective drug or at too low of a dose or for too long of a time period. So you want to treat at a high dose with an effective drug. It doesn't mean to be like some big exotic drug that's reserved for multi-drug resistant staph infections, but just something that's likely to work against the pathogens likely to be present. And make sure it's a drug that you can give at sufficient frequency. So if you can only do once a day, then you only get to choose from once-a-day drugs. And if you are prescribing a twice-a-day drug and you find it's only being given once a day and there's a choice that's more expensive that is once a day, realize that's going to be a cheaper drug in the long run, even if it just means it shaves a few days off each case of upper respiratory infection. As I said, you want a second choice with different spectrum than the first choice, and you want to have a consistent pair of drugs. It may not always be the same pair. It may not be the same pair for every shelter. For many shelters, doxycycline is one of the pair, and then you want something else that's likely to cover those gram-negative and the broader spectrum of secondary pathogens that might be playing a part. You want to evaluate early and often in a shelter. So don't just start them on drugs and treat for 10 days and then say, hey, they're not getting better, or hey, they got better 5 days ago, and now they're sick again. So you want to start them on treatment. Look at 3-5 days into treatment. If they're not responding to the drug of first choice, switch to the drug of second choice. So make that decision fairly early when they've had a chance to respond. And if they're better after 5 or 7 days, go ahead and stop treatment instead of just continuing on treatment for a full 10-day or 14-day course. And the reason for that is you're not trying to create a sterile environment in the upper respiratory tract. So it's not like when you're treating a bladder infection or something. You're not trying to get rid of all the bacteria. You're not going to be able to do that. And so there's not any real justification for continuing treatment long term. One caveat of that is that if monitoring is very poor and the people are only spending 5 minutes in the isolation area and they think symptoms are all gone a few days before symptoms really are all gone, then you might need to continue treatment for 2 or 3 days after the last time an animal was noticed to be sick. But try it a little bit and see how it works with the monitoring quality in your treatment facility. Make sense? And this, look how happy she is. At this shelter, as soon as a cat sneezed or just looked a little bit off, they would assault it with lysine and B vitamins and sub-Q fluids and move it all around. And they had a massive outbreak of respiratory disease. They thought it was Bordetella. And we did some diagnostics, and it was herpes. And when they just lightened up and stopped messing with the cats, when they just sneezed a couple times, the outbreak magically disappeared. So you want to do supportive care, but don't overdo it. So I talked about practical considerations. Use something that is practical in your environment, even if it's a little bit more costly on a per tablet basis, because the real cost is the care per cat per day and the cost of administering it. Do no harm, 1 set of drugs per cat. So we've known of outbreaks that were transmitted on a common syringe used to administer drugs to cats with upper respiratory infection. And the outbreak was much more fatal than the respiratory disease. And if you're using doxycycline, you probably all know this, but it needs to be either given as a liquid or followed up with a liquid. We have recipes for mixing doxycycline on our website. If you type in doxycycline, you'll probably find those. Okay to mix it with milk products, dairy products. Okay to mix it with chicken soup. Not good to mix it with mineral syrup because that can bind the doxycycline and reduce its availability. And some commercial mixing formulations contain citric acid, and citric acid plus doxycycline in an expired formula can be very toxic to the kidneys. And some research that was recently published from North Carolina found that it only lasts, once you've mixed it up, for 7 to 14 days. So even though commercial formularies might make liquid doxycycline that's labeled to be stable for a year or two, according to these researchers, they haven't been able to provide any data to support why that would be the case when it hasn't been the case, when they've been mixing it, as far as they know, in the same way. So I wouldn't trust that. I'd mix it yourself, and I'd remix it every 7 days. I really like to see shelters have a consistent plan for treating upper respiratory infection. It's sort of like, these symptoms, do this. These symptoms, do that. Fails to respond to this, try that. And the reason for that is one, that staff can become familiar with the drug and the side effects and the dose, so they can kind of know if something seems off. And also so that you can evaluate whether overall one antibiotic is suddenly being less successful, which might mean that you have something different going on, or that the antibiotic mix, the bacterial mix that you're dealing with is suddenly different, or if there's something else going on with your treatment protocol, maybe the antibiotic's not being given like it used to be, and you need to check on compliance. And if you're sometimes using this drug and sometimes using that drug, it's hard to say whether it's the drug that's the problem or the treatment that's the problem or just something else going on. Make sense? So we have an example of this. If you go, and you can get a PDF of these slides, so you can just click on these active links, or if you just type treatment into our search box at sheltermedicine.com, you can download a sample. And I'm not saying use this exact thing, but this is an example of how you would say, if these symptoms, then that drug. If this, then that supportive care. And I think probably for a lot of you this just goes without saying, but it's surprising how commonly we run across this, that cats are being treated in a shelter and it's not being written down every day how they're doing. And so a veterinarian comes in every 3 days, every 5 days, or, someone is coming in trying to decide whether treatment is working, but nobody wrote down how the cat was doing. And so it's really hard to say. Maybe it's looking bad today, but actually it was better for 3 days and it's just worse today. Or maybe it's been looking bad this whole time. So have a treatment sheet that includes daily observation of signs of food intake, of urine and fecal output, and then, of course, written dose, duration, and the initials of the person giving the drug, so you can know, is it a drug problem or is it a not being given kind of problem. So we have a sample treatment sheet that you can download on our website, and then you can monkey with that if you like, or use something. It doesn't have to be super complicated, but just make sure that signs are being monitored in writing. It matters where treatment happens. So the environment has probably as much impact or more impact on the success of treatment as whatever antibiotic you're actually giving. And probably the most common reason why treatment doesn't work is just crowding in isolation areas creates such a bacterial load in the air that the cat's immune system just can't get ahead of it, and antibiotics can't get ahead of it. But some other things to consider. This is a study that showed the effect of dog noise on cats that weren't sick. And so it was stressful for cats that weren't sick. The more dog noise exposure there was, the more stressed they seemed to be. But it was even more stressful on cats that were sick. And that's not surprising. But it's sort of heart-wrenching to think about. Like, these poor cats, they're sick, they're kind of scared, and then they hear the noise of a predator somewhere right around. If you can't control dog noise, do make sure that cats that are being treated for respiratory infection have some sense of visual protection, whether that's a towel over part of their cage or a hiding place within the cage that allows you still to monitor them, but allows them to feel like they're kind of hiding. I showed you this one, and this was awesome. For those of you who don't read Oprah, this is my reward for traveling. I subscribe to Oprah, and then I hoard my Oprahs, and I only can read it when I'm on the airplane. This is in the latest issue, and it was about room for recovery, and it had the impact of a bunch of different components of treatment rooms on hospital patients. And this doesn't just apply to cats being treated. I think it really applies to cats trying to stay healthy, and even cats trying to get out of shelters alive and find homes. And I'm not going to go a lot into this, but just private room. Not only were residents less likely to catch the flu when they had a private room, but they got more hours of sleep. And I think, we can think about cats in group housing always having to kind of be on the alert if there's a lot of other cats around and there's some social conflict in that environment. And I think just thinking about, a lot of shelter cats are actually exhausted. This is true of shelter dogs too. Sometimes you'll get them out of the shelter and they'll just sleep and sleep because it's quiet and they feel safe, maybe for the first time in a while. Carpeting, I'm not advocating for carpeted treatment areas and shelters, but visitors stayed about 8 minutes longer on average when rooms are carpeted, and people recovered more rapidly. So just thinking about shelters in general as being an environment that's warm and welcoming to visitors, because when visitors stay and observe animals, then they adopt animals. But also thinking about treatment areas as a place where, especially if treatment's going to be prolonged, where there is an opportunity to sort of interact and for the cat to have some normal time where it gets to be out of the cage and it gets to have some socialization, as well as just not having antibiotic treatment be the only thing that is about human interaction during its day. View of nature. People stayed almost an average of a day less when they had a view of nature instead of a view of a brick wall, and they needed fewer pain medications. And this really pertains to when oftentimes when we set up feline housing, we'll set it up so that they're not looking right at another cat, but we set it up so that they're looking at a blank wall. So thinking about just giving them, cats are very visual creatures, and in all housing areas, giving them some opportunity for visual stimulation, something to see. And, we talk about it as being a good thing to do, but here it showed really the impact on well-being and health as well. Sound-absorbing ceiling tiles, more restful sleep, and a lower rate of rehospitalization, so a quiet environment. Not, again, necessarily sound-absorbing ceiling tiles, but just thinking about making it quiet. And when hospital rooms were adaptable so that patients didn't have to be moved from room to room to room, then there was fewer mistakes, fewer delays in care, less miscommunication, and errors fell by 70%. So when we think about that in terms of shelter cat care and shelter animal care in general, think about just not making their path through from intake to adoption too complicated, and having something that is theirs that stays with them at least through their full time in the shelter, whether that's bedding or a carrier if cage size is sufficient to accommodate a carrier, so that they're not completely disrupted from their environment multiple times throughout their time in a shelter's care. In a light-filled window, death rate runs about 61% higher in facilities that lack natural light, and people who recovered in sunny rooms took 20% less pain medication. So these things really have an impact, and a lot of times the feline respiratory infection treatment room is like the most dungeony, awful place in the whole shelter. And I know it takes some creativity and some investment and some funds sometimes to make that change. And I'm going to talk about some ways that maybe that can change and ways that that can pay off in the long run. While I'm on the subject of horrible isolation rooms, any of you have horrible isolation rooms? I see some sadly nodding heads. If you have decent quality housing where the cats they're not in with a bunch of other cats that don't have upper respiratory infection, and you don't have to take them out of their cage every single day to clean them. You don't have to get all over them. So you have a nice condo where the cat can kind of stay and you just tidy up around the cat and it just sneezes a few times, and your isolation room is horrible. Think about just mildly ill cats. Just leave them in the place where they are. Put a big sign on them saying, I'm under medical treatment, clean my cage last, volunteers not to handle unless approved by manager, and just don't move them unless they progress to the point of needing antibiotic treatment. You may have more success with that if you're not already doing that. Just want to mention quickly the problem of chronic or non-responsive upper respiratory infection. So you guys see this where a cat doesn't respond to the first round and it doesn't respond to the second round. And if that's a common circumstance, the first thing to really look at is conditions in the isolation area, so that's one thing. And then flow through issues from treatment into whatever happens next. So it's not uncommon to have an adoption area that's full and all backed up, and then there's no room to move the cats out of treatment. This was my hell that I was in when I decided to go to the shelter medicine residency, right? When the shelter's all full, adoptions is all full, treatment is all full, there's cats waiting in line to get into treatment, there's cats waiting in line to get out of treatment. By the time they get out of treatment, they already got sick again. So those issues need to be addressed. So if there's not room to move the cats out of treatment that are being moved into treatment, that needs to be addressed when cats are being moved into treatment. And then finally, a policy issue, again, if this is common, and sort of at the shelter that I showed at the beginning where we saw healthy euthanasia go down but medical euthanasia go up as a percentage of euthanasia, and we saw the overall sort of shelter death rate go up. Sometimes, and I'm hoping, since you're sort of earlier in getting to zero, that you can avoid some of the screw-ups that we've accomplished in the United States. You say, we're not going to euthanize healthy animals. Yay. But you still have more animals coming in than you have going out. And it might not be a lot more, but it's just a few more coming in, and then you have going out. And so they don't go out, and so they sit. And what do cats do if they sit and they get crowded? They get upper respiratory infection, then they're treatable. Then sometimes they get euthanized as treatable, but sometimes you say, you know what, it's time for us to pick off the next level. We're not going to euthanize the treatables. And if you're still taking in some more that come in healthy, then go out, then you get through the treatables, but the treatables get sort of backed up because the healthy ones aren't going out, and then they turn into untreatables. And then you're euthanizing the untreatables. So that's the first thing to look at. If you're seeing an increase in the number of untreatables, make sure it's not an unintended consequence of a basically positive impulse. Then if it's just the occasional individual animal that just doesn't respond to treatment like it should, look at it as an individual animal. Take it out of the shelter medicine mindset and say, there's no law that says this individual animal can't have some particular problem, like a polyp, like allergic rhinitis, like a seed up its nose. Look at the pattern, look at the age of the animal, and see what the risk factors are for that individual, and make a diagnosis as you normally would. But make a decision about it. So if it hasn't responded to 2 rounds of effective treatment, that's the time to make a decision. Not after 2 months, not after 3 months, not after you've poured a lot of money into it, not after it's sat in a cage for a quarter of a year. There are some diagnostics that are pretty consistent with just knocking a cat out for desexing surgery, and you can just do these at the same time without a great deal of additional cost. So those can really help guide your decision. I'll just talk about this a little tiny bit more before I talk about chlamydia. Some cats just need to get out of a shelter. So for whatever reason, their immune system can't cope with the shelter environment. So think about just getting cats out of the shelter. Sometimes you can do the diagnostics, do a nasal flush when they're in for surgery, and then send them into foster care. The foster care person needs to understand that that cat may never recover, but it may well recover either in foster care with no additional treatment or just with antibiotics directed at whatever you find based on these additional diagnostics. I just want to let you know, chlamydia, as I said, is rare, but it only responds to doxycycline, and it only responds to doxycycline in some cases long-term. So if you have suspicious clinical signs of chlamydia, and it tends to cause conjunctivitis, or you have an initial good response to doxycycline, responds in the first few days of treatment, and then when you take it off treatment, the cat gets sick again, and then you put it back on treatment, and it gets better again with doxycycline, continue the doxycycline for at least 4 weeks. So that shouldn't often be the case, but when it happens, it's really helpful to know. They're no longer contagious once clinical signs have fully resolved, so they can go up for adoption, they can go into a home, but the treatment needs to be continued, or they may have a recrudescence of their signs. If you don't have chlamydia, then get them out of the shelter. Choose an antibiotic with good penetration into bone, and I have a little list of them up there, and I think I also have these in your notes. If it responds within the first week, then you want to continue for 8 weeks if you have a chronic non-responsive upper respiratory infection. So again, they didn't respond to 2 rounds of sort of reasonable treatment. And obviously that really should be happening in a foster home or in an adoptive home. And I'm a fan of adopting these cats to people who live very far away. So if someone comes over from the United States for a conference, you've got a chronic snotty cat, give it to them, make sure it doesn't sneeze until they leave, and then it's out of your hands. But don't keep them in limbo in isolation. Not good for the cat. It's not good for the other cats either. So now just in the last little bit here, I'm going to get back to the fun stuff. Cat comes in, bright and shiny. A couple weeks later, it's all crusty. Even if we can treat her, it's a big waste of our resources, and it's a big patch of misery for her. So how do we stop that? So some of you saw this, the disease triad. We don't get to choose about the cat, really. We get to manipulate the environment and sort of protect the cat against what we know about the behavior of the germ. And we have the advantage that we know we're working with herpes virus. So we really want to tackle the stressfulness of the environment and lower the infectious dose of germs in the environment. But we're really going to emphasize stress because of the nature of herpes and its natural cycle. Here's a problem, and could have been from almost anyone. Cat housing and upper respiratory infection. And this shelter director had asked me, what kind of housing can I put in that's going to control upper respiratory infection? What would be better than what I've got right now? And I said, well, one thing is I can give you all kinds of magic tricks to reduce your risk of upper respiratory infection, but you have to tell me that you have some other plan for managing the population than waiting to see who gets upper respiratory infection and euthanizing those ones, as those are the ones too many that came in. So we saw that upper respiratory infection accounted for about 30% of the euthanasias from the RSPCA, and I would guess that 30% of cats don't come in needing to be euthanized for upper respiratory infection, and I would guess that if I gave the RSPCA a magic wand and I eliminated all the upper respiratory infection, would that eliminate that 30% of euthanasia? Who thinks it would, that euthanasia would drop by 30%? Probably not, because probably what's happening is homes aren't being found for some cats, and so some cats are getting upper respiratory infection, and then it's being used as a crutch in decision-making. We totally did this at the shelter where I worked. It was a lot easier to choose a cat because she started sneezing than it was to choose a cat that wasn't sneezing yet, because we simply had admitted more than we placed in that time period. And however, if you always do that, you're always going to have upper respiratory infection. You can get better at this and better at that, and you're going to raise the bar of crowding that you can get away with before you get upper respiratory infection, but eventually you'll have to get it to make up whatever difference you have between intake and outcome. So, cat, germ, environment, and management. We do have to have a management strategy that controls the population in some way that's not URI reliant. So our tools for prevention, here's a lot of them. But crowd control has to be the foundation, because if we're overcrowded, then we just can't keep up with the other stuff that we need to do. And this slide, those of you who were here on Tuesday couldn't see it, but it shows the relationship with density and upper respiratory infection. So these blue bars are the number of cat care days, or the daily cat population present in the shelter. And these boxes are the risk of upper respiratory infection per cat per day, so independent of the number of cats present. You can see that as population density decreases, there's a lag period, and then risk of upper respiratory infection decreases so that it's about a third of what it was at its peak. As population density increases, there's no grace period. It goes right back up. Why is there such a strong relationship with density and upper respiratory infection risk? Stress. Stress for cats, stress for who else? Staff. When you have more cats than you can really handle, staff is stressed, staff is running, things are not happening well, vaccinations aren't getting given, food intake isn't being monitored, sneezing cats are being missed, they're not being removed promptly from the population, and the whole system just slows down. Another thing that happens when the system slows down and when there's more cats present, so at this shelter's peak, they had about 200 cats present, and at their trough, they had about 60 cats present. What if they adopted out 1 cat a day? When they have 200 cats present, how many days are cats going to spend in the shelter, on average? Someone who is here on Tuesday. Adopt 1 cat a day, 200 cats in the shelter. 200 days. They're going to spend 200 days on average. And they're going to have a lot more chances to catch upper respiratory infection. If you have 60 cats present and you adopt 1 cat a day, they're going to stay 60 days. So oftentimes you adopt out more than 1 cat a day. So if you have 60 cats present and you adopt out 4 cats a day, they're only going to stay 2 weeks each. But if you have 200 cats present and you adopt out 4 cats a day, they're still going to stay 50 days each. They're going to have a lot more chance to get upper respiratory infection during that time period. So just having more cats present means a longer time in the shelter, means a greater risk for upper respiratory infection. So that's why I'm a huge fan of controlled or scheduled intake or appointments for intake. I'm a fan of it even for stray cats, just to say, you know what, we're not ready to move this cat swiftly through just yet, so why don't you hang on to it until we're ready to just shoot it on through the system and out the door. And this is just revisiting that graph that shows the risk, the relationship between time and upper respiratory infection. Just hard for cats to keep it together for a really long time. And this was a little study that we did for a shelter that this was their time to adoption. And so it ranged from about 2 weeks to about 3 weeks. And we gave them a target day goal of 12 days. That was 5 days in stray and 7 days in adoption. And this was a shelter where also they could be viewed on the internet. During their stray period, they had a reclaim rate of only about 2%, so really functionally all the cats were going to make it through to adoption. So 12 days was a pretty good goal, and they could reduce their daily population by 35 cats on average if they just dropped their length of stay from 2 to 3 weeks to 12 days. It was a pretty big shelter, so a few days made a pretty big difference. We don't do this by increasing euthanasia, so just want to remind you. Euthanasia and upper respiratory infection. In the community that had the lowest upper respiratory infection, The shelter cat deaths, or euthanasia, per 1,000 capita was 4.6. URI prevalence was 3%. In shelter 9, that had about 34 times as much upper respiratory infection, shelter cat deaths were almost double, and the URI prevalence was over 5 times. So crowd control basics, and I'm just going to give you more resources on this. But it is the foundation of feline respiratory disease control as well, because it gives you the chance to do the other things that work. Remember, you don't save lives by putting cats in shelters. You mostly save lives by keeping cats out of shelters, by keeping them from being born. And then you save the rest of the lives by getting cats out of shelters. And the more cats you have in a shelter, really potentially the less lives you get to save. If you can't reduce the number coming in, A, question that. Really? Can't you? Or can you at least slow it down? And B, reduce the amount of time in care per cat. Do that by reducing the amount of cats in care at any one time. Go from 200 to 60. And magically that'll sustain itself by improving health and by improving care. That's the way that you reduce the time in care per cat. Repeat that as necessary. And solve overpopulation by getting yourself one of these. Resources on capacity, more than I can get through in this brief time. But I have a lot written about it on our website. And this is just an example of a shelter that reduced the number of cats present from 24 to about 12 by giving each cat double the space in their adoption area. And they saw I'm not going to go through the math of this right now, but they brought themselves to what we define as adoption-driven capacity, and you can read more about that on our website. So they brought themselves to their perfect adoption-driven capacity and also dropped their population by half. And, was Dr. Hurley's recommendations. Decreased our adult cat population, gave each cat more room, have connecting condos, so we just opened them up, decreased our cat numbers to 12 to 13, and we saw our adoptions increase by 29. Cats are less stressed, and URI is non-existent. So I used to think this was just a theory, but enough people have done it now that I've seen it play out, that adoptions increase at the same time that density decreases and care and health improves. If I'm wrong about that, and you try it, and you see adoptions decrease, do let me know. I really do want to know if in some situations this doesn't work. The one time we saw it maybe not work so well is that the shelter felt so great about not having crowding in their adoption area that they forgot to run their adoption specials. So don't stop running your adoption specials in the middle of summer just because you don't have cats coming out every crack of your adoption area. Still do them. Just do them by your schedule instead of doing them in reaction to crowding. So that makes me feel awesome. So now what? Get crowding under control. This was the study that we did of the 9 shelters for a year. We looked at 49 different factors. We had shelters fill out this exhausting questionnaire, and then we made them count every frequent case of upper respiratory infection for a whole year. And then we put about 250 million data points into a computer, and it made a grinding sound. And the data came out, and there was 2 factors that mattered. And the 2 factors were greater than 9 square feet, and that's about a square meter of floor space, but not 6 to 8 square feet. So a medium-sized cage wasn't quite good enough, and a small cage was a risk factor for upper respiratory infection. So it's not a huge cage, but it's bigger than a small cage. And notably, it was big enough for the cat to be able to pretty much lay down at full body length, stand up, have good separation between its food and its litter box and its bed. And all the large cages were double compartment, so the cats didn't have to be moved from one cage to another or handled a great deal for their first week in care. And after their first week in care, they actually moved to small group housing at that particular shelter. But it was the cage in the first week that came out to matter in this study. And the other thing that mattered was limited movement in and out of the cage in the first 7 days of care. And again, all those large cages were compartmentalized, so limited movement and large cages went together in this study. Probably both important. And I won't really get into this. I'm going to finish up very shortly.
Sorry.
In about a minute, which will be awesomely fast.
It will.
Here are the housing basics. You can read this on the PDF. You can talk to us about it afterwards. Danae, can you just wave your hand? Danae is actually the practical expert on making this happen. But I just want to show you how one shelter did it. So here's the shelter that was spending a third of their days of care on feline upper respiratory infection, and it was making them mad. And it was as compared to the shelter with the bigger cages that was spending less than 1% of their days of care on feline upper respiratory infection. And they weren't that fancy of cages. They were laminate. They weren't steel cages. They were, each side was only about that big. And so it's an attainable goal. So that was their old housing. They bought a modular building. They bought laminate cages with a bedroom and a cubby hole for litter and a resting bench. They put cats in it. And the dotted line is their upper respiratory infection risk per cat per day before. Here's the red arrow is where they made the change, and this was their upper respiratory infection risk per cat per day after. During that time, they actually increased their intake. They saw no increase in euthanasia. And they had over 1,000 fewer sick days the summer after versus the summer before. This was the email that they sent. This was actually over a year later. Never in my wildest dreams would I have believed I'd see the day with one cat in feline sick bay. Today is that day. This is all the cages that they had. And they had one cat in there. And I took this picture a year after that when still feline sick bay was almost completely empty. So if you want to try this, you can get, cubbies, condos with cubbies and built-in holes and double-sided and so on. But if you have smaller cages and you have the wherewithal to get a plasma cutter, you can cut holes in them. You can put portals. There's various ways to do it. And again, Dr. Wagner is happy to talk with you about doing this. You can do this really for very cheaply in terms of material costs. And having half as many cages does not mean you get to save half as many cats. If they stay healthy, if they stay behaviorally sound, if they move through faster, you actually get to save more cats too. So it is a win-win-win situation. I'm not going to talk about any of this. You can read about it. This is just an example of someone who took all my advice. I went there to her shelter at lunchtime, doubled up their cages, provided a hiding place by covering up one half, giving the cats an up and down area, giving the cats an exercise area for some out-of-cage time, renaming their volunteers kitty butlers instead of kitty cuddlers, so they put the cats' names first, and really saw a dramatic reduction in their feline upper respiratory infection and spent no money at all. So it doesn't have to take a bunch of resources. It has to take a commitment to really providing cats what they need. But when we provide cats what they need, we see less upper respiratory infection, we see healthier cats, and we see greater success as communities too. It really is like there's no downside, you just got to believe it. So, thank you.
Thank you so much, Kate. I know it's really hard because you've got so much information. But thank you very, very much.